All right. Welcome, welcome. Happy March. All right, March comes in like a lion. It's really coming in like a lamb here. But anyway, so I'm Teresa, I'm the MC director. I have three announcements for you today. First of all, we are announcing Evan Roberts. Can you please stand and say hello to everyone? Is the new Izzardy training director. He'll be taking over for Rob Warren. He is faculty in the History of Medicine program in the med school and a longtime member of both the NPC and LCC. Evan will fully take over on July 1st, and in the meantime is going to be shadowing Rob for the rest of the spring semester. We want to give a big thank you to the search committee. You can raise your hand here. Fabio Boltz, Lindsay Fabian, Dave Hacker, Dave is here, myself, and Rob Warren. So please join us in welcoming Evan. Congratulations. Second of all, applications are open to join the Population Studies branch of the Izzardy training program. So please see our Izzardy training page for more details. Applications close in a month on April 3rd. Very exciting opportunity. All right. And then third of all, the Izzardy Winter Olympics are this week. Da, 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 da. On Wednesday from 3 to 4 p.m., please come right back here to participate in this fun, lighthearted concoction of Winter Olympics inspired games. Very exciting. Put your team together today. So now on to our speaker for today. Dr. Sarah Gollust is a professor in the Division of Health Policy and Management in the UMN School of Public Health. She is a founding member of the Collaborative on Media and Messaging for Health and Social Policy, an interdisciplinary group of researchers who study how media and messaging shape public opinions, attitudes, and behaviors. Dr. Gollust received her PhD in Health Services Organization and Policy from the University of Michigan and completed a postdoctoral fellowship in population health science at the University of Pennsylvania. Sarah, here is the coveted seminar mug that you can only get by presenting here. So thank you so much. We look forward to your talk.
All right. Hopefully, folks on Zoom can hear me. And it's just really wonderful to be here with all of you, getting to share some research that I and a team, many of whom are in the room, got to have the privilege of working on for the last 3 years. So I want to start just by acknowledging the Robert Wood Johnson Foundation, which funded all of the work I'll be talking about today. The views, however, do not necessarily reflect the views of the Robert Wood Johnson Foundation. So as I was thinking about what to do for this presentation, I decided to do kind of a broader overview rather than a deeper dive into a single study. Over the last 3.5 years, our research collaborative, the Collaborative on Media and Messaging for Health and Social Policy, which is many, many words, but it can be acronymed to COM, Collaborative on Media and Messaging. We have done a tremendous amount of work that I'm very, very proud of. And so I thought, as I was thinking about what I wanted to package today, that I would talk sort of really broadly about sort of the research approach that I take in studying the intersection of communication and health equity, and then do some spotlights on some specific studies that have, I think, some pretty replicable kind of evidence-based take-homes, lessons that we can move on from here and that hopefully will be relevant to your work in different ways, even if you're not a communication scholar, as you think about how the work that you do gets translated, whether by design or by happenstance, to the public and to kind of the political sphere. So specifically, I'll spotlight some of our public opinion research on awareness of COVID-19 health disparities. I'll talk about some of the challenges that communicators in the field of practice of communicating about health equity shared with us. And then I'll talk about some of our emerging evidence from survey-based experiments on different messaging strategies for engaging with talking about equity and equity-related policy in a really divisive communication environment. And so I think about the goal of this research team and sort of my personal goal as contributing an understanding of how communication can be a vehicle for reducing health inequalities or advancing health equity. And when we think about communication research, and when I think about sort of where my research sits in with broader health communication, there's a variety of pathways that research engaged in communication can pursue in thinking about that outcome of reducing health inequalities. So you can study or design strategic communication campaigns. So this should be familiar to all of you just from kind of your own, either your own work or just living in the world. Things like public service announcements to shape behavior, the strategic dissemination of guidelines, practice guidelines, professional guidelines that come out, and advertising and marketing, both advertising that's explicitly for health promotion or advertising that is sort of incidental to promoting health but can have either positive or negative consequences on people's health. There's also the broader media environment that can shape health inequities or equity. And people, engage in that either strategically on purpose or by accident. There's health information that's conveyed in advertisements, in news media, in entertainment media, even, and that can affect how people think about and respond in their own personal lives and behaviors. And then a third way that communication matters for health equity is thinking about interpersonal communication. So this would be communication with a clinician or a provider in a healthcare appointment, or interaction of community members with other types of service providers, if we think broadly about the social policy environment that shapes health and health outcomes. But there's also the threat in all of these pathways that communication can actually increase health inequities or exacerbate inequity. And this is because we know that populations are not equally able to act on information. So if we just provide health information in the absence of other resources to help people become equipped to act on it and resources to change their behaviors, which include policy level resources, um, communication is more likely than not to expand inequity rather than improve it. And so I think an important threat to think about when understanding the relationship between communication and health equity is that because of the fundamental inequalities in resources, communication always has the potential to expand existing inequalities. All of that aside, I'm really interested in the sort of research team that I'll be describing is really interested in a fourth pathway, which I'll call here the pathway through politics. So thinking about how communication about health equity related topics or policies related to health equity um, can be portrayed in mass media, thinking about whether those issues are portrayed in high or low frequency, the kind of quantity of the coverage, as well as the quality or the content of the coverage, the specific ways these issues end up getting described in mass media. And I say this is a political pathway because this information and the information environment can affect how people, public and policymakers alike, how much they're aware of these issues, um, the extent to which these issues are on the public agenda or policy agenda or not, how people conceive of the causes of health issues, how people conceive of the appropriateness of solutions. And in general, there's research that suggests that these types of communication pathways also influence how likely people are to be mobilized to address health harms. And again, just as I described on the previous slide, this pathway can also have kind of intended and unintended consequences. And this is all the context that our research team has been engaged in for quite a long time. So my colleague Jeff Niederdeppe at Cornell University, he and I met in 2006, I believe. Teresa knows the context through the Health and Society Scholars Program, the postdoc program we were both in. And we began almost immediately in our shared interest in understanding how communication about health disparities might shape these types of political outcomes. We put together this conceptual model that we published in 2013. And one piece of it that we were really concerned about was how broader public discourse about health disparities might inadvertently induce unintended outcomes among the public. Things like reactance or negative response to messaging about health disparities, potentially perpetuating political polarization around these topics, and potentially activating negative stereotypes about the communities who suffer from inequity. And so there was a long, actually, so this is the type of thing where we actually worked on this in 2009. It was published in 2013. So we've been thinking about these issues for a very long time and got the opportunity to develop a robust infrastructure to address these issues, how communication about health equity gets received within an environment where polarization, backlash, or negative reactions is highly likely, which really defines our post 2020 environment around health equity information in public discourse. So we had the great fortune of being funded by the Robert Wood Johnson Foundation to create this collaborative. Again, too many words, but it does abbreviate to COM, based on this sort of articulated need for more and better and rapidly responsive research around health equity in the environment that we saw after 2020, which was characterized by sort of this backlash to health equity in public discourse alongside reactance to public health authority after the COVID-19 pandemic. So in our grant proposal, we identified kind of 3 core hubs for this research endeavor, cited at Wesleyan University, Cornell University, and here at the University of Minnesota. And we defined these hubs by kind of the core tasks that they would engage in, but that we would have this sort of reciprocal relationship across all 3 institutions. So my colleagues at Wesleyan generally focused on media monitoring, so including real-time media surveillance, looking at local TV news, for instance, looking at closed captioning in local TV news to identify keywords and look at the quantity of coverage of certain words and concepts over time. They also were able to provide us with data where we could do deep dives into, for instance, the Minneapolis TV news media market for a project led by some of our RAs around homelessness in the local media context. So Wesleyan did kind of media coverage as well as conveying data sets to us, including ads and news that we could then analyze. My colleagues at Cornell University engaged in many survey-based experiments. I'll talk about a few of those at the end of this presentation, with the idea of using rigorous, replicable survey-based experiments to understand the impact of messaging on survey sort of samples of the general public. And then we here got to do all sorts of fun things, did some content analysis, some survey work, some experimental testing of messages, but with a specific focus on engagement, engaging communities of practitioners, including community organizing advocates and public health practitioners, as well as engaged in strategic dissemination with the idea of we wanted to get this research to be useful more quickly into the community. Core elements of our approach have been rigorous research that's responsive to the dynamic information and policy environment. And so our colleagues at Wesleyan were able to do this monitoring of the news and advertising environment for content and topics related to health equity over the course of the 3.5 years. We also did some evidence syntheses, trying to make sure that we were knowing what the research literature was, compiling that and sharing that back out, and then conducting survey-based experiments. So here we are. This is just a few snapshots of the research team. Another hallmark of the team, besides the capacities that I just described related to how we did our work, is our interdisciplinarity. I got that one. So political scientists, communication and journalists, scholars, psychologists, and health policy and public health folks. This is a picture of us at the Campus Club in 2023 when we, I know people are like, there's some stars in the room on these slides. When we held a retreat across our broader team with our Cornell colleagues and our Wesleyan colleagues. And here's a photo of the best team of the 3, obviously, when we met in last summer. And so with the research funding, we were able to fund infrastructure for this research. And I think that's what made this grant, I'm using past tense. So spoiler alert, the grant ended on December 31st. We're very sad. But the way we were funded was we were able to fund the team and the data. So rather than an Ames-based research proposal where we said we're going to do all these things, we said we don't know what we're going to do because we're going to spend the first year engaging with the community of practitioners to find out what the biggest needs are. But we are going to have faculty at every site, postdocs at every site, research assistants at every site, and a robust data budget at every site so that we can deploy research to be responsive. So I mentioned before that one of our capacities was monitoring the communication context. And so I just wanted to show you kind of what this looks like when I say we did real-time monitoring. So this was contributed by our Wesleyan Media Project colleagues who did searches of the closed captioning in local TV news over 5-year time to understand the dynamic environment around health equity and structural racism over this time period. So you can see here, I saw some people already kind of get what they're seeing. So the y-axis is keyword hits on these terms. So this first keyword was structural racism mentioned. And we see across the time axis, we have 2020 all the way up till 2025. Does anyone want to shout out a wild guess of what that peak was? Yes, you all win. So there was an enormous spike in attention to structural racism in June of 2020. It was not sustained, right? So you can see there was some intermittent, returns, but in general, this was not maintained. So they also did keyword searches of two other terms, critical race theory and then DEI. And we can see this kind of predictable pattern of sort of competition in the media environment where a spike in attention to structural racism is followed by a little blip around critical race theory at around the same time as that second blip. So this is when there started to be attention to these concepts when state legislatures were introducing bills around, not permitting critical race theory to be taught in schools. And then we see the enormous spike at the onset of 2025 in attention to DEI. So another way we were monitoring the communication context is through surveys, understanding public opinion about this landscape of health disparities and systemic racism, as well as interviews with communicators. And I'll do a quick kind of a little dive, not a deep dive, a mini dive into each of those. So in terms of public opinion about disparities, this is one of the first papers we published with the new grant. We conducted 4 waves of surveys immediately after the onset of the pandemic, so starting in April 2020, August 2020, April 2021, and then we were able to follow up with a 2 years out time, or 3 years from the start in April of 2023. We used NORC's AmeriSpeak panel, which is their representative panel, online panel for interviews. We used their omnibus for 3 of the waves and a custom survey for another wave so that we were able to have these repeated cross sections where we asked the same 4 questions about public understanding of disparities in COVID-19 over time. Again, just a snapshot of the findings here. One major finding is that we found across those 4 time points from 2020 to 2023 that majorities of the public, well over 70%, if you just squint and look at the length of the blue bars, that's the percent who agree or strongly agree that there are 2 types of disparities. Disparities by chronic illness, so having a pre-existing condition predisposed people to mortality from COVID-19, as well as age, with the survey item being that older people were more likely to die of COVID-19 than were younger people. And so the key point here is that sort of robust and pretty persistent understanding of those 2 types of disparities in COVID-19 over time. But much lower if you squint again and look at the size of the blue bar now. So under 50% of the samples across the 4 years and actually declining recognized that there were disparities by income for these 4 bars and race for these 4 bars. So pretty middling, if not disappointing, levels of recognition of disparities that we all, demographers and others, knew very clearly and knew almost immediately after the pandemic's onset. So rather than seeing like a growth in recognition that there are class-based and racial disparities in COVID-19, we did not find that at all. And further, given our interest, the team's interest in political polarization, we assessed whether there were differences based on survey respondents' political affiliation as a Republican or a Democrat over across the four survey waves, again, April 2020, August 2020, April 21, and April 23, in their recognition of these four types of disparities: chronic illness and age, and income and race. And you can see for the first two, there were none. So none of these bars are statistically different from one another. Republicans and Democrats did not have different views on the existence of disparities by chronic illness and age for COVID-19 mortality, but dramatically different perceptions of income-based and race-based disparities in COVID-19, where, as one might expect, Democrats were significantly more likely to recognize these disparities than were Republicans. In that 2023 survey, we also had the opportunity to repeat a question that RAND had asked previously in surveys around recognition of systemic racism as a particular cause of these disparities in COVID-19. So we just used the text that came from RAND's survey, also an RWJF funded survey. I'll read the wording out just because I think that's useful. And the sort of rationale for testing public understanding of this concept was because, in the time between 2020 and 2021, there were an enormous increase in cities, municipalities, states, and even the federal government identifying structural racism as a public health crisis. And so we wanted to know, do people sort of understand that idea, linking systemic racism to health outcomes? So the question says, systemic racism refers to policies and systems that reinforce racial discrimination and unfair treatment of some groups, such as where people get to live or who gets bank loans. This type of racism can be so embedded in the institutions and practices of society that it can still exist even if individuals don't want to discriminate. How much do you agree or disagree with this statement? One of the main reasons that people of color have poor health outcomes, we included their question, which was higher rates of diabetes and more deaths from COVID-19 than white people, is systemic racism. And again, we found this strikingly polarized pattern, where 30% of respondents overall agreed, of a pretty low number. I mean, we can debate glass half empty, glass half full. It seems low to me, but just over half of Democrats and far fewer, 40% fewer, in fact, independents and Republicans agreed with this statement. So summarizing kind of what we learned from these attention to public attitudes, we see overall lower public recognition of COVID-19 disparities by race and SES, strong evidence of partisan differences, which we hypothesize could be due to different health information selection or a sort of resistance process in receiving or being exposed to this information, and strong evidence of polarization in understanding of systemic racism. So the next research that we did to kind of assess the ground to inform the work of the broader collaborative was interviews with 36 communicators to understand their strategies, barriers, and where evidence would be most useful for them. And the rationale here was we wanted, as a collaborative, to conduct research that would be most relevant to communicators, right? To thinking about understanding how we can get the research done that they actually want to see. So we published this paper last year. Shout out right here, Quinn and Saran, both authors, on the paper. And so we interviewed these 36 individuals across public health practitioners, equity organizers, community advocates, thought leaders, and journalists, and asked them, what are you doing? How are you talking about health equity in this time? And again, this is 2022, 2023. What barriers they face in their communication, what resources they rely on, and in a separate investigation also, we asked but reported it elsewhere, what research questions they have that they would want to see addressed and what their preferences are for dissemination to them. So if we were to develop research, how do you want to receive it? So one feature of this project was that although we did eventually prepare a publication, as you saw that we published last year, we also wanted to make sure that the interviews, what they were telling us, we were able to disseminate rapidly across the other parts of our research team. So we did really fast field notes, coded those field notes, and communicated those to the broader team, actually, with the idea that it was setting our agenda for the second 2 years of the grant. And so the first phase was a sort of team-based rapid qualitative analysis before the sort of more in-depth coding effort of the full transcript. Okay, so again, just to sneak peek at the findings, because the paper is already published, communicators faced a lot of challenges in talking about health equity in 2022 and 2023. Concern about alienating particular audiences. Partisanship came up, but so did talking to rural folks as compared to urban dwelling people about health equity. How explicit to be about racism or not came up many times in the interviews, and how to center race in their communications versus other salient identity dimensions. Lots of concerns around backlash. Some even identified research papers that had come out around that time that suggested backlash was probable, and they were concerned about that. And they talked about a lot of different sources of resistance among audiences they were seeking to reach among the mass public. So just a couple quotes to highlight some of these challenges. We heard from a public health professional at a state health department who's grappling with this. How do I talk about health equity to so many different types of audiences? And they said, sometimes I think there's tension around a focus on elevating health for people of color and American Indians. But I'm always a little worried about, like, if you're a poor white person who's like, what about me? Why don't you care about me? Or an advocate who talked to us about, if we can't talk about systemic racism, well, that's like denying sociological fact. You're denying evolution and gravity when you're denying structural racism, right? Other challenges were more systemic or institutional, not about the audience per se and their feedback, but about the environment and organizational culture in which they were communicating. So, in talking with the 8 journalists, we heard about gatekeeping by reporters or editors, systemic racism in their own media institutions that posed challenges for how they were getting their stories relating to health equity and systemic racism out to the public. Lots of resources and capacity limitations. For journalists in particular, the challenge, the sort of difficulty it is to construct a really good health equity news story within the constraints that they face. And then more broadly from the public health communication perspective, just a lot of fragmentation across communicators. So just as an example of one of the journalist constraints, when you only have 5 hours, meaning 5 hours to file a report or a news story that relates to health equity, the only person you're probably going to talk to is a public information officer or a doctor. They're the ones who are available. But when you create the community story, you have to work on your own time. You have to get those sources a week, 2 weeks in advance. So just thinking structurally about how hard it is to create a really sort of community-centered news story about health equity. Or with regard to the racism within media organizations, one journalist told us about their editor constantly asking, can you really say it was racism? You're having to explain over again, like how racism works in healthcare. So that's how systemic racism thrives, not only within what gets covered, but also in terms of how things are covered. So overall, they shared us that they're not using research in their reporting or in their communicating, which wasn't terribly surprising to us, but also is a big gap given that there is a robust body of research in communication studies and public health about communication. But they were interested in research. They were certainly interested in having evidence help them overcome some of the challenges they described to us about communicating in this fraught environment. But they really weren't sure how to access it. So we heard a couple. I have a friend who works in a school of public health, and they sometimes are able to get me an article that I can use, right? So this sort of information gap between how our research gets stored and produced versus how they can access it was really real. And they were certainly interested in kind of more resources in trainings and messaging guides and the kind of communication infrastructure that could support them. So some of the urgent questions that we surfaced and then became part of our agenda for the next 2 years of the project were thinking about, how do we communicate about disparities? to have maximum impact and not induce backlash. Lots of effort, which is ongoing, on how do we depolarize, how do we increase institutional trust, science, media, as well as public health institutions. How do we deploy different types of frames in communication that promote assets, not deficits, within the communities who face structural inequities? What role do values have in communicating? And then how do we think about creating new narratives that are community centered or Black centered? And we've started research on all of these domains that came out of these interviews. So just to summarize this phase, we found communicators faced really substantial challenges in their efforts to communicate about health equity, that they have interest in research to help them, particularly to identify communication strategies that are evidence-based, that can mobilize diverse audiences or reach resistant ones. So I think a key question that came out of all of this foundational work, the survey work, the media monitoring work that identified the sort of cardiac pattern in attention to structural racism, critical race theory, and DEI, and the interviews was, does discussing racial inequality inevitably produce polarized response? So that was sort of the question that we in the leadership team of COM were just struggled with. And this was a question that has been discussed in elite media as well. So here's just two example op-eds in the New York Times asking the same question that the interviewees asked us when we talked with them. Should Biden talk about race or class, or should he not mention race? That Democrats' racial politics do more harm than good. Pretty bold claims without a huge amount of sort of replicable research evidence to support, I would argue. So we sought to do syntheses of literature. What do we know about this question, about disparities messaging and its effect on different types of publics? And so my colleague Jeff and our postdoc at the time, Jaiwei Liu, put together a sort of meta-analysis, a narrative synthesis, actually is what it was, on the 17 studies that they had found that addressed this question about the effects of communicating about health disparities. Unfortunately, they did find that there are some negative and fairly well-supported concerning consequences to communicating about health disparities. They found that communicating about health disparities can reduce perceptions of risk among the lower disease prevalence group. So when you say, Black people have this chance of heart disease, white people have this chance, when you go back and ask the individuals identified as white, what are your chances? They actually lower them more than would otherwise be their sort of risk. We also found that, I'm not on the study, they also found that there were negative emotions aroused within the higher disease prevalence group when you set up these sort of comparative, this group is higher risk than that group. And they did find evidence of sort of negative and politically polarized reaction to disparities messaging on support for preventive measures and policies. So it didn't look good from the surveys, from the synthesis of study perspective. And so we wanted to then develop a set of studies that could further understand, well, are there ways that communicators can discuss racial disparities, the causes of racial disparities, and the evidence-based solutions to disparities in ways that can increase public understanding and motivate action and not trigger backlash? And so we collected a lot of data, lots and lots of data. And so these are just the 8 studies that the Cornell team led over the last 2 years. Our team also led an additional study that's not even on the map here, with different types of contexts, so different health topics, different types of messages, obviously across from 2023 to spring 2025, and very robust large sample sizes. The advantage of having the sort of dedicated survey budget that we could draw from was we could deploy a series of experiments to kind of replicate and build on this core question. So in my 11 minutes, I'm just going to do a sort of summary of 2 of the studies that we published last year. So the first, led by my colleague Neil Lewis Jr. at Cornell, who's a communication scholar and psychologist, we published this article giving away the key finding in the headline here: beyond fear of backlash, effects of messages about structural drivers of COVID-19 disparities among large samples of Asian, Black, Hispanic, and white Americans. And then another study led by Jeff Niederdeppe and colleagues looking at the question of how to communicate about an evidence-based policy to advance social equity, which was the child tax credit expansion, and looking at the effects of communicating about this policy issue among historically minoritized populations. Okay, so first study, and so this is the context of COVID-19. So responsive to some of our public opinion work, we wanted to understand, again, is it inevitable that talking about structural causes of inequities produces polarized reactions? And so we conducted two pre-registered survey experiments, one using the Prolific survey platform and one using prime panels in 2023 and 2024 with intentional oversamples of Black, Asian, and Latino populations. Because some of that work that we synthesized that looked at that construct of backlash either used general samples that had, by design 70-75% white participants in them or exclusively white populations. And so we wanted to know, okay, well, when you include more diverse samples, what do you find? And respondents were randomized to two conditions. One, we can think of as a disparity only, or the idea that we sometimes hear like disparities speak for themselves, like this idea that if you just tell people about disparities, people will, come to care about it. So the context of this experimental treatment was, a little bit of information about COVID-19, and then said that COVID-19 infection is 400% more likely to lead to the hospitalization of Black compared to white US residents. And that we can think of as kind of the control, sort of your typical journalistic assessment or summary of disparities. And then our treatment group provided a structural explanation for those disparities. So as an example, these differences in COVID-19 infections and death are due to longstanding patterns of discrimination. Historically, many of the laws and policies enacted by legislators have had the effect of limiting where Asian, Black, Indigenous, and Latino people live. As a result, they are more likely to live in densely populated neighborhoods, conditions that make it much easier for COVID-19 to spread. So in addition to talking about the disparity, provided structural explanations for why that disparity exists. And importantly, we made the choice not to use the term systemic racism in describing it, but just explained what that systemic racism actually looked like. And we found no white backlash. So we did not see that exposure to, so these figures, the red bar are the intervention or the structural explanation treatment, and the gray bars are the control or kind of disparity only treatment. And so across these groups, there's a few key themes. First is that we found higher levels of engagement, support for COVID-19 mitigation, and willingness to advocate. We had a battery of sort of advocacy actions someone could take and asked about the survey respondents' intentions to engage in those actions. So we found the minoritized respondents in the surveys showed the deepest engagement with these health equity issues, that there were racial differences. So white respondents showed lowest support and lowest willingness to advocate, but without understanding that the intentions and support were much higher among racially minoritized respondents, we might draw a sort of incorrect conclusion about the overall population's interest in engaging around health disparities, and then no evidence of lower levels of support among or intentions to act when exposed to that structural explanation. So that's just looking at the differences between the gray bar and the red bar among white respondents. In all cases, they were higher. Maybe not substantively significantly in all of the tests that we did, but never were they lower, which was the kind of key backlash finding we were seeking, hoping to avoid. Okay, the last study I'll describe was trying to understand how to communicate about not the causes, which was the focus of the social science and medicine study, but the policy solution. And so we focused on the child tax credit because some of the community partners in this project from Community Change were really interested in the child tax credit. It was just after the child tax credit had expired in 2021, and some states were thinking about extending it. And there was robust empirical evidence that the child tax credit had boosted children's levels of poverty. The opposite. Reduced children's levels of poverty, and that had particular benefits for Black and Hispanic children in particular. So we designed a study, they designed a study, I'm not on this one, with a control condition that then again just described the child tax credit and said it's ending, and it included a call to action to advocate for its continuation at your state legislature. A universalist message, which included that same introduction and call to action, but also used a value led policy, a problem description, which again, the sort of advocacy and organizing community has been doing for a long time, this idea of values first. And so that message began with, while every child deserves the opportunity to pursue their dreams, this country was founded on the principle that everyone should get a fair chance to succeed, and then proceeded with the main content of the message around child tax credit. And then also included a policy efficacy statement, basically saying the temporary child tax credit expansion in 2021 was highly effective in reducing child poverty for everyone. And then for our targeted universalist message, it went on to say, but its effects were even larger for Black and Hispanic children. So explicitly talking about race within the context of the message. And we also found no backlash to these descriptions of the equity benefits of the child tax credit. We found both of our intervention messages, our universalist and our targeted universalist messages, produced increased support and increased intentions to act, uh, write a letter to the editor, contact a legislator to support a child tax credit expansion. That the universalist message did increase support among white respondents. The targeted universalist message did not, but it was not lower. So that explicit reference to the benefits accruing to Black and Hispanic children did not reduce support among, when we look at this based on race as well as based on partisanship, and did not see that targeted universalist message that was racially explicit reduced support among white or Republican respondents. We have another paper under review that we replicated the exact same design of the child tax credit experiment with the three conditions, the sort of control condition that just described information and a call to action, the intervention that used values and then policy efficacy language universal, values and policy efficacy targeted around two different topics. This was in April of 2025. So the first was on maintaining Medicaid funding. That didn't actually happen. The the big beautiful bill was passed a few months later, but the idea of this survey was try to understand, are there different messages that could activate people's to call Congress to be engaged around supporting Medicaid funding, and then expanding access to opioid use treatment. And again, spoiler alert, this is still under review. We didn't see backlash. We found increased support and intentions, but it was particularly in the opioid treatment expansion arm. The Medicaid one did not see many experimental effects, probably because it was just a fraught time for discussions of Medicaid in the first place. Okay, so summarizing lots and lots of studies over 3.5 years, some sort of promising communication practices that have come out of our research is kind of this idea of beginning with broadly shared values does seem like an approach organizers are taking, other advocates are taking, and it does seem to blunt the likelihood of a reactance response by partisanship or race. Our study, the one I mentioned, led by Neil Lewis Jr., suggests explaining core concepts, not relying on shortcuts like words like equity or systemic racism on their own, and expecting that to sort of be broadly understood among general publics is unlikely, but explaining the core concepts does seem to make a difference. Don't allow disparities data to speak for itself. It doesn't speak for itself, and what it might be saying might be counter to what we are expecting it to. Emphasizing policy solutions, particularly how they work and for whom, and backlash. It's not inevitable, we hope. All right, I want to acknowledge the Brig team. This, I said before, is sort of this is like my love story to the ComHSP initiative. It was such a pleasure to get to be leading this work since 2022. I want to acknowledge the leads from Cornell and Wesleyan, Jeff Niederdeppy, Eureka Franklin Fowler, Jamila Mishner, Neil Lewis Jr., Breeze Floyd, Norman Portatellis, Stephen Moore, and many, many others. And then, but huge gratitude to the best team from our University of Minnesota hub. Several of you are in the room, have been engaged with MPC across multiple departments at the University of Minnesota. So Quinn, Duran, JMeg was involved in one of our studies with our postdoc. There she is. You hid from me for a moment. So thank you so much. Extra slides.
Hello, Dr. Gollust. Thank you so much for this presentation. It was really interesting. And one thing I've been thinking a lot about is, and it seems like this is part of the findings across the studies done about like the use of the shortcuts or
Yeah.
the buzzwords. I've been thinking a lot about why that causes maybe like more of like a response or a reaction or a backlash or so visceral.
Yeah.
And this the research that you presented seemed to kind of explain a little bit about the importance of maybe moving away from things that can be like harpered on to, like for instance, acronyms like DEI or
Mm.
BLM or all the other things, but just like being very explicit about like how you're explaining the terms. And I don't know if you've also come across other forms of literature on like just using those shortcuts, and if you have more to say about that in particular. But that's something I'm really interested in and would like to hear more about.
Yeah, thanks for that question. So yeah, I think that is one conclusion that sometimes because of the broader, so in my work, sort of thinking about the political psychology of how people respond to information, people who, whether they're answering a survey or they're seeing something in the media or wherever they're getting their information, it's activating a certain set of considerations, right? And so, depending on who the last person to say those words was, or the construct that sort of is linked to that in your head, you're going to draw from that when you're answering a survey question or kind of making up your mind about an issue in policy. And so, if you've been hearing this construct of DEI used in a certain way with a particular negative valence, and you wouldn't otherwise know what that means, that is going to be part of why we think that that can trigger kind of a misunderstanding or at least an incomplete understanding of the concept. So, yet when respondents read, if, unfortunately, it's fairly lengthy, right? The shortcut has value if it can communicate within people that understand the term a particular set of ideas, because it takes a lot more time to explain how laws passed over generations produce exposure to different types of living environments which which then affect people's exposure to disease. But people got that, right? Like that was understood in a way that I think the shortcut brings in the kind of heuristic baggage of however that term is used in public discourse. So I don't. I mean, there's lots of research on this kind of general idea, but it's like thinking about right, the heuristic or shortcut that someone might be thinking about and where that comes from, I think is key in thinking about how to leverage these words and what the goal of the communication is and who the audience is. So if it's like people here in the room, it's probably great to say health equity and systemic racism because scholars have produced evidence on what those concepts mean for so long and it's a shared understanding and it's a shortcut. But if that's not your audience, then there may be different ways of explaining core concepts that are more helpful.
So this is
Yeah. Yes, I don't know. I mean, we have not. We have, surveyed 40,000 plus people, and they've all been U.S. residents. So I can't speak like empirically to that question, but I share your intuition that it's a product of the U.S. the racial politics of the United States, and to be blunt, the leadership in the United States that is producing the cues and heuristics that people are gathering. Yeah.
This is so interesting. Thank you so much for coming over here. So you say backlash is not inevitable, and I buy that. But sitting here in 2026 in Minneapolis, it would be hard to argue that there hasn't been a pretty significant backlash. So is it just people using the wrong terms in messaging, or is it possible that the backlash is actually happening once people get out of the survey, then they talk to their friends, and their friends have something on social media, and then all of a sudden they get animated on this, and the backlash is actually happening, but the survey can't pick it up.
I think that could be true. I think, confine the backlash is not inevitable. Yes, of course there's backlash. I mean, we've started the whole grant on the premise that there was backlash that we wanted to try to understand. But I think what we are finding is within this context of the survey artificial world, it's not inevitable that people should draw a conclusion that leads them to misunderstand health equity and say they will not advocate for its amelioration. So that is promising. And yeah, what happens after that? Agree with you. But I also think it does a disservice to be overly cautious and say, well, we can't talk about these things that are important, that, racial injustices and historical marginalization that affects people of color specifically. If we think we can't talk about that, I do think that's problematic.
This was great. Thank you for presenting. Um, I noticed that your team used a panel for this, and I can understand why that would have taken you probably twice, three times as long to be able to poll that many people. Um, do you anticipate that you would see similar conclusions if you had sampled those people rather than relying on a panel?
Yeah, that's a good question. So I think the question underneath the question is that we're using survey panels like Norc Amerispeak. We used Prolific. We used YouGov. We used Lucid. We used So we're using survey respondents who you could think are weird folks, right? They are volunteering to participate in research and they take a lot of surveys. So that is a big limitation. I think the way when I put the list of the 8 surveys we done, we used different panels. So it was they're all weird, right? So the evidence adds up that maybe they're all weird, but all these different types of people are weird in the same way, I think still gives us some, sense of comfort that we're seeing replicability even in different types of panels. But you're right, we did not have the budget to start we did not door knock to collect new survey respondents for these studies. We relied on existing survey forms and existing panels for research. So yeah, maybe the results would have been different. And I think that maybe that gets at Andy's intuition too, that maybe when you are talking to real people in their real lives who are not the weird people that answer surveys, we would see different findings. So yeah, that could be true. Yeah.
I would just comment on that additionally, that number one, all the panels aren't the same. So some are
Yep.
internet opt-in quota samples that you just mentioned, and some are nationally representative address-based sampling. So I wouldn't group them all together. Secondly, if it's an internet opt-in panel, you could have, we said 40,000 people, but you don't know that because people could be in multiple panels. So when you're using an internet opt-in panel, you could have people that are in more than one panel, and researchers don't often check and see if people might be in more than one panel. So I just wanted to mention that.
Yeah.
At the same time, I thought it was very compelling. It did make me wonder, like, what if you went to the state fair and showed some people? I don't know. I did think about
Yeah.
how it would
We're
look
going
in
to the state fair.
person. So you are okay, good. Awesome. Well, I'm excited to have you follow up at MPC in the next few years and tell us that then.
We have a Driven to Discover site or whatever for this August. Yeah, with Kumi Smith.
I just had a question about the graph with the white backlash. So when I look at that graph,
That one?
yeah, I'm wondering from one of the graphs or something like that, it looks like the white backlash that you were looking for was still relatively small compared to the control. And I'm wondering if that is just motivated by political affiliation, just because most white people, not maybe not most, but like there are more right leaning or Republican people in like the white population. So I'm wondering if you did any sort of like stratified analysis by like race and political motivation, just to see what's like
Yeah,
motivating that difference.
yeah, we did. And yeah, both of these papers are published and have pretty. I printed out all the long. They were all pre-registered, and so they have all of these like practically a manual of materials that include the results stratified by race and partisanship. Um, so the I'm happy to. So these are the two studies, both published last year, with extensive. Everything was pre-registered, so all the survey instruments, the data, everything is available, the code, and so yeah. But you can check them both out. Hmm. Hmm. Yep. Mm-hmm. Mm-hmm. Um, no, we have not studied empathy in particular, although you reminded me that that did come out in some of our interviews with communicators, that the strategy of sort of establishing a sort of an empathetic rapport, or um, in organizing and political movements, they talk about that in deep canvassing, and the idea of like in that one-on-one, like doorway conversation, establishing empathy is key. So I'm sure there's literature. I do not know it well, so I can't speak to that. But that is part of that is kind of what some of the motivation for starting with a sort of values statement is, to potentially reduce, sort of establish a common ground, reduce the likelihood of just a very heuristic reactance response. It's establishing that you have some kind of something held in common, like we care about kids. Now I'm going to tell you about the child tax credit. And so that's in the social psychology literature that's been, um, if not emerging, sort of beginning to be established as an important part of communicating about, potentially divisive topics. But empathy, specifically, empathy would be a good for our to-do list when we get more research.
I have a question about when you get more research funds,
Mhm.
your ultimate goal about what kind of communication you want to see be successful. So you have found some wording where you don't have a backlash, right? But it
Mhm.
also looked like including that information about the racial inequity didn't increase support or make people more likely to want to do something.
Mhm.
So is your goal to just, I guess, find ways that the backlash isn't going to occur, but you can still disseminate that information and ideally people are still learning something? Or do you want to construct a message such that the messaging on racial inequity increases people's willingness to act, if that makes sense?
Yeah, no, that makes perfect sense. And I will say that this first stage was, we were attacking the like New York Times question, right? Like, which was specifically, is it unproductive to talk explicitly about racial groups who benefit from policy? Right. And yes, longer term, the idea of understanding what can actually meaningfully increase various groups among the public's willingness to act is key. But these set of studies that I described were really more designed around this question of sort of like, what is a productive way of it beginning a conversation? Yeah.
All right. I one last question before we let you go. I wondered, across all of your scholarship, what you have found to be the best message to provoke political action.
I won't answer that
Duh.
because I don't believe in like silver bullets, right? Like I don't think there's a best message. You like queued up one of my favorite talking points. Like, there's not going to be like if we all just did this, because it depends on topic and it depends on context and it depends on audience, depends on the goals of the communication. So each of these studies actually had different, like they all had some common elements, right? But we weren't trying to test like this one best thing in this context. So no, I won't answer.
Okay. Well, thank you so much. Let's give a big hand for Dr. Gollust. Thank you.